Welcome to Apical Diagnoses, another introductory video on endodontics by me, EndoGal. Today we're going to go over each of the possible apical diagnoses, but first we'll need to review some key anatomy, how to read radiographs, and then finally we'll get into determining a tooth's apical status. So first let's look at some key dental anatomy. I'm going to draw the outline of a tooth here, including the enamel and the pulp, which I'm drawing now. And I'm going to color that in pink. And here's the dentin. And at the top of the pulp, we have the pulp chamber. And extending to the root apices, we have the root canals. Here's the apical foramen, which is a tiny opening that allows nerves and blood vessels to pass through and supply the pulp. Other portals of entry include the lateral canals, the furcation canals, and accessory foramina. It should be noted that each of these passages, which normally allow healthy tissue to enter the tooth, can also be where pulpal inflammation, infection, and necrosis can spread to the tissue surrounding the tooth, aka the periodontium, leading to the diagnoses we see today. The next thing we'll do is take a look at a dental radiograph. Since many apical diagnoses will rely on radiographic changes, especially in the apical region. A light spot on the film, like this one, is known as a radiopacity. This arrow is pointing to a restorative material, likely amalgam. A darker area on the film, like the inferior alveolar nerve canal, is known as a radiolucency. A key radiolucent area that you need to know about is the PDL space, which holds the periodontal ligament and surrounds the entire root surface. The radio-opaque band that outlines the PDL space is called the lamina dura, and it's compact bone that surrounds the tooth socket. This irregular meshwork that you see here is known as trabecular bone. And now I'll label some anatomic features of the tooth, like the enamel, the dentin, and the pulp chamber, as well as the root canals. Finally, in blue, I'll highlight the root apices, which are especially important for today's video. The first diagnosis we'll take a look at is normal apical tissue. Here I'll draw a little schematic of a radiograph with trabecular bone, the radiolucent PDL space, as well as the radio-opaque lamina dura that surrounds it. This type of tooth is not sensitive to percussion or palpation tests. So I'll draw a little green arrow to show that it's okay in this way. And on radiograph, we'll see that the lamina dura is uniform, meaning that the PDL space is intact. So here's a real-life example of this diagnosis that shows that the lamina dura is intact. We can see that the PDL space is uniform around the entire root surface. Next, we'll take a look at asymptomatic apical periodontitis. So here's another drawing of a radiograph with trabecular bone. But in this case, inflammation from the pulp has spread to the tissues surrounding the apex. Since it's asymptomatic, we don't have symptoms to percussion, palpation, biting. However, we do have a periapical radiolucency on the radiograph. And I'll draw that in here. So these are some examples, and they show periapical radiolucencies, which indicate inflammation has spread to the bone. Our next diagnosis is symptomatic apical periodontitis. Again, I'm going to draw our tooth sitting in trabecular bone. And just like our last diagnosis, the inflammation has spread out of the pulp and into the apical periodontium. However, here we do have pain on percussion, palpation, and/or biting. This diagnosis may or may not be accompanied by a periapical radiolucency on X-ray, since the pain has already been confirmed by periapical inflammation. Next, we have acute apical abscesses. So here we have the tooth in question, which has experienced serious pulpal inflammation, leading to an abscess on this root apex. So the way it goes is that pulpal infection and necrosis leads to inflammation. This brings about sudden and spontaneous pain, as well as pus formation and swelling of the associated tissues. This type of tooth will be very tender to pressure, and it may or may not show radiographic signs like a periapical radiolucency or constitutional signs like fever, malaise, lymphadenopathy, etc. As a contrast to acute apical abscesses, we have chronic apical abscesses. Again, I'll draw our tooth in question, but now we're looking at it clinically, not radiographically. Hence, the gingiva is obscuring our view of the roots. Here, that same pulpal inflammation will lead to slow onset of little or no discomfort. Most notably, we'll have a sinus tract, which will allow pus from around the root apex to drain directly onto the gingival surface. This will be an on and off drainage that you can see clinically. On a radiograph, you will probably see a periapical radiolucency indicating inflammation of the surrounding bone. Note that the sinus tract can be traced with a gutta percha so that the origin of the pus can be confirmed on radiograph. So here I've included a clinical photo of a chronic apical abscess's sinus tract. It's that little nodule right there under the first molar. Below, we can see how the origin of a sinus tract can be traced by threading gutta percha through the orifice until sufficient resistance is encountered. Then the practitioner takes a radiograph like the one on the right to confirm where the pus is coming from. So here we can see the point of the gutta percha. Our final diagnosis is condensing osteitis. So here we have low-grade inflammation that leads to a bony reaction that shows up on X-ray as a diffuse radioopacity. I'll draw that finding below. So here we have the trabecular bone, and there is a radioopacity or light region surrounding the root. Here we have a real-life example that shows this radioopacity. This indicates low-grade inflammation. Finally, here's our summary slide of all of the apical diagnoses you need to know about. Thank you for watching. I hope it was helpful.